Sir, which classification you follow, sir?
Dr. Bishnu, I think Dr. Deepak has already done a great job in explaining us all the classification systems. Any classification system that we may follow, all we need to understand is what is the unstable variety. I
Okay.
think any classification system anyone follows, as long as we know what is unstable type, unstable types need a nail, and the stable types can be well done with the DHS. No matter what classification you use, I normally tend to use the AO classification system. But whenever I have doubt, all I think about is stable, unstable.
Okay.
Stable, DHS or nail, anything. Unstable, nail. That is the key for me. And if I go to more of A3 fractures, then I start thinking about both nail and plate. That is the only difference. So I think the key here is just to understand what is stable, what is unstable. No matter what classification, almost all of them tell you the same thing. They may be different grades. It is just for communication. But the core message of all the classifications for me, I think, if I have to send a take-home message is learn what is stable, learn what is unstable.
Yes.
Stable fractures need a nail. Stable fractures can be dealt with a DHS or a nail both. That is the key, I think, for me.
Thank you, sir. Rastogi, sir, do you have the same page or have different opinions, sir?
Yeah, I think in general, I agree with Dr. Samarth. There is actually nothing like, there is no point in classifying these fractures. Basically, what you need to do is
Yes,
understand
sir.
which one is the only rider I wish to add is that stability and instability should be decided after you have put the patient on the table and you have tried to reduce it.
Yes,
Okay,
sir.
sir.
Yes.
Okay, very nice, sir. Thank
So,
you, sir.
so classification just on the basis of an X-ray when the patient presents to you in the emergency is of no value.
Okay, sir.
So once you have put the patient on the table, you've tried to reduce it, then you can actually find out. So a lot of people to establish, see, the question here is how is your implant going to fail if you have done it wrong? If you have done it wrong, then it is going to fail somehow or the other. And there are only basically two modes of failure. So you have to guard against both these two modes of failure. So you need to find out where it is unstable or where it is stable. As far as DHS versus PFN is there, that's a completely different
Different talk. We'll come across in the
story.
coming
So I don't
lectures.
think I'll be going into that right now. But what I wish to say is don't classify when the patient comes to you. Classify when the
Table.
patient is being prepped for surgery.
Okay, we can
After
take a couple of more questions. If any other faculties or anybody has any questions, you can take. Other next, we'll move to the next lecture. Any questions from anyone? Either Dr. Gunjar, is there anything in the message box, or any faculty want to add any comments to this?
Message box.
Okay, there is one question. Can you elaborate on the two modes of failure in management of IT fracture? Would you like to? Anybody wants to like to answer this question?
I think that will come later, I think, Dr. Vishnu.
Okay, okay. We'll come to this question later on. Doctor, please be in the webinar. We'll come to that question.
The X-ray per se traction internal rotation view helps a lot to classify it.
Okay.
Yes.
So from the first lecture, I can say this endpoints that classification is basically to decide whether it's stable or unstable. 1 point. Second point is it should be done after on the fracture table once we stabilize or reduce the fracture. So these two or any other points you can add on. And next we'll go to the next topic by Dr. SAMARTH MITTAL. So he will be speaking on tips and tricks of IT fracture reduction and fixation using a short PFN. Over to you, Dr. SAMARTH.
Dr. Deepak, you need to stop your presentation.
Yes, sir. Thank you. Thank you, sir.
Thank you, Dr. Deepak.
Thank you, Dr. Deepak. I think with your presentation, things are really easy for me now. So, is my screen visible?
Yes, sir.
Yes.
It's visible.
And
Nice.
it's full screen?
Yeah, full screen. Fine.
So, okay. So, over the next few minutes, I think I'll be talking about the tips and tricks in reduction of intertroch fractures. I think I've talked to Dr. Gunjar, and thank you, in Bhubaneswar, Dr. Vishnu, Dr. Gunjar, for having me. I think I've talked to Dr. Gunjar and had a pretty good idea of what our audience is, and I've slightly tailored the presentation according to the audience that we have. So, in case you feel I need to go a little higher up, I can do that, or if you want me to come down to a certain level, I can do that as well. So I think when it comes to intertroch fractures, we need to understand what are the displacements in this fracture, whether the fracture has gone into flexion or the fracture has gone into extension, whether it has gone into varus or whether it has gone into valgus, whether it has gone into external rotation or it has gone into internal rotation, and how much of a shortening or lengthening there is in this fracture once you put them on a fracture table or any sort of a thing. So just whenever you look at any fracture in the intertroch region, just start thinking whether it is in flexion. Most of the time it is in flexion. Very rarely will you get a fracture in extension, which is less than 5% of these cases. Most of the time these fractures will tend to go into varus, but a certain epsilon variety will tend to go into valgus, and you need to understand that. Most of the times you need to internally rotate the limb to reduce these fractures, but sometimes you have to be open to the concept of external rotating also to reduce a fracture. And then you need to understand that most of the fractures at the time of the fracture will be shortened. And when you put them on a fracture table and lengthen them or give them the length, don't over distract a fracture. It is difficult to over distract a fracture, but fractures don't like distraction at all, and these will lead to non-union. So you need to be careful about it. And I think if there is one paper that anyone needs to read is this 2009 publication published in JOS, where they have talked about the 10 tips to improve results. There are a lot of copies of this paper. A lot of other authors have written about intertroch fractures, but I think the one paper that really pushes me about these fractures is this by Hajdukovic. And if there is any time for you, please go ahead and read this paper. I think just to start with the basics, it is the position of the patient that matters a lot. You need to put these patients in a banana sort of a position, and you need to ensure that the patient upper torso is not straight and the leg is not adducted. The moment you try to do that, the whole pelvis gets tilted and you don't get any extra benefit with the adduction. The moment you do the banana position, the torso goes towards the opposite side as the fracture. That is the time when the pelvis stays straight and you get a clear lever arm to get the reduction right in adduction, as well as you get a entry point when you're trying to make an entry over the GT. So you be very careful. Don't ask your assistant to place your positions, because unless you have a patient in a banana position, it becomes very difficult to nail, especially in a very fat sort of a patient who has a lot of fat, or people with a lot of big laterally protruding iliac crests, where the entry will become really, really difficult. Once that is done, you need to decide what sort of a surgeon you are, whether you do it on a fracture table, you do it on a supine table, or a lateral position. Most of us do it on a fracture table, and most of us keep the opposite leg flexed in a Gopal traction tong, or some of us may use the scissor position. It depends on surgeon to surgeon. But as long as you have the other leg out and that leg is not pushing your pelvis in a circle, and you can get a good AP and lateral view of your intertroch region, I think the job is done. Once that is done, what else do we have when we put the patient on a fracture table? I think first thing is traction, and the traction is two components. One is gross traction and the other is fine traction. The other is the rotation, where you put the foot and you can rotate it internal or external. And the third is the flexion and extension of the distal fragment. And I'll talk about how you can slightly correct this when you're doing it on a fracture table. So the first thing is traction. I think we all have different kinds of fracture tables, but most fracture tables will have one gross level of traction where you position the patient and you leave some scope for fine traction, and you can increase or decrease the fine traction to get a good reduction. And the other is the rotation of the leg. This leg holder at the leg end, this is straight up, and you can internally rotate it or externally rotate it to get it good reduction. And the third is flexion of the distal fragment or extension of the different fragment. While some fracture tables will not allow you to do this, but other fracture tables, if you can see my laser pointer, so other fracture tables will move up and down like this to get some flexion or extension correction. This may not be possible in every sort of fracture table. So you can move this bar up and down to slightly correct your flexion and reduction. Now, most of the times, the goal of reduction is to avoid any flexion, because most of these fractures will tend to go into flexion all the time, and to avoid any sort of varus at any given point of time. So, and the general dictum is to reduce a fracture before you start fixing it. Although in the hands of great experts, this is not a key, but otherwise, as a general dictum, this should be followed. Now, how to reduce? The moment you start giving traction and slight internal rotation, most of these fractures will fall into place, especially the stable varieties. And then check under CM. So rule of reduction is, just by traction, you can correct the varus and valgus. Most of the time when you position these patients, they will be in varus. And the moment you give traction, slight traction, you look for the medial calcar. And the moment it falls into place, you've corrected the varus, and your varus and valgus will be right. If you have too much of valgus just decrease the traction and it tends to correct the varus and valgus. There are so many other ways, but this is the easiest way to correct the varus. And on the lateral view, you look for the internal rotation and the external rotation. The moment the anterior cortex, the anterior cortical line, mind you, this line, don't look at the posterior cortex. This is the compression side. The tensile side is this one. So on the tensile side, just look at this line and this line. So proximal and distal fragment, just look at the anterior cortical line. And the moment it becomes congruent, it means your internal external rotation is fine. Yes, if the fragment is up and down, then you can correct the flexion and extension at the distal end to correct that as well. But this is the line that you need to see in all your reductions. And if you can't see this line, rotate your C-arm, because most of the time the lateral view is not an exact lateral view. You need to rotate the C-arm to a less lateral view to get a best lateral view of the hip. Once that is done, the nailing becomes easy. You get an entry point in both AP and lateral view from just medial to the tip of GT and in the center in the lateral view. And then you ream in the same path, nail in the same path. And now Dr. Deepak has already told us about the unstable fracture types. I think anything that has posterior-medial comminution, a large banana fragment. He's explained to us about the AO-OTA classification, where all A2 fractures will have a thin lateral wall, which is a lateral wall less than 20.5 millimeter, because the moment you try to ream it with a DHS reamer, this lateral wall will blow out and it will turn into a reverse oblique pattern. That's why they are now called unstable fractures. In the old classification system, they were still called the stable variety with the intact lateral wall. If there is a lateral wall comminution or blowout, lateral wall coronal split, if the GT is a separate fracture or pattern altogether, or which is a stable looking fracture in a very osteoporotic bone, I think it is a sum of all the classification systems that I find is if you have any of these things, then it is an unstable fracture pattern. And my go-to message is if you have an unstable fracture pattern, only a DHS will never be the key. Yes, in the hands of experts, maybe it will work. But for most of us normal surgeons, I think we need a nail for these fractures. And you may get to a very complex fracture pattern, the one I'm showing in the figure. As long as you know what is varus, valgus, flexion and extension, just keep checking in. And see, the trick that I have used here is I've used a ball spike in the image to the left here. The moment I make an entry point, I think there is some amount of varus, and then I correct this varus by putting this ball spike into the proximal site through the nail entry point site, and I correct the varus and fix it in normal. And again, this fracture shows some flexion here. The only thing I do is through the nail entry point site, I put on a Homan and move it towards the roof or the ceiling of the OT, and I correct the flexion that is there. Very bad looking fractures, the moment you take them on a fracture table, they improve. But this is a rare variety where you see the ischial to prosthesis here and the proximal fragment has gone down. So this is the extension kind of a fracture. And again, through the nail entry point, only thing I have done is put in a Homan through the fracture and lifted this up and push this down. And the moment I get it corrected, I will get a good reduction and fixation. So you need to just worry about correcting the varus, valgus, flexion, extension, and any rotations that may be there. And you need to look at a good lateral view before you put in your guide wire. The moment you have a perfect lateral view, your guide wire will usually go center in both AP and lateral view. There are a lot of tips and tricks that you can use. For an epsilon variety of a fracture, the iliopsoas gets fixed between the fracture, and all you need to do is, yes, people say you need to do open reduction, but if you want to do a closed reduction, all you can do is put a Shantzman in the proximal fragment, take a Homan, just run over the GT and push it into the fracture fragment and push it out. Just lever the fracture out. Once it becomes reduced, it stays reduced. Or sometimes a posterior medial fragment can get into the fracture in a very rare situation and cause you a problem in reduction. And that time, all you need to do is just remove that fracture from the small fragment from the fracture side to get a good reduction. And a simple example that I'm showing here is an intertroch fracture, which is in flexion, which is in varus. All I've done is first put in a Homan in the front through the nail entry site to get the flexion right. The moment I have the flexion right, you see the amount of distraction there is and the fragments away from each other. Then I make a stab incision on the lateral side and put in this collinear clamp on the proximal fragment and just try to compress it. So I have one Homan and one collinear clamp taking care of reduction. That is the incision there. That is the entry point for the Homan site, and this is the expected site for the blade from where the blade is going or the screw is going to go in for the collinear clamp. And then you put in the nail, follow all the steps. You see here how I've used the, instead of a ball spike, I've used the nail tightener jig at the top to get the valgus right. It was in slight varus when I was trying to put in the wire. And once all this done, then you have these compression screws on the screw or the blade. and the distraction, you see how it will decrease from one image to the other. So you can just compress the fracture, and that is the incision required to do this. And this is the post-operative X-ray of the patient. So with this, I will end my talk to save some time. I think the take-home message is pretty clear. The take-home message is a stable-looking fracture can behave like an unstable fracture pattern. I think reduction is the key. Look at what is varus. If there is varus, give more traction. If there is flexion, try to put something from the front. If there is rotation, try to internally rotate or externally rotate the limb. If there is shortening, give more traction. If there is lengthening, decrease the traction. And look for signs of any irreducible fracture. You start using a nail or a DHS only once the fracture is reduced. I think that is the key. Only in the hands of great experts can you break this principle. And if there is any doubt at all, just keep a very low threshold for opening the fracture and getting a very good reduction, because a well-reduced fracture will definitely heal compared to a fracture which is not well-reduced but biologically more stable. And no matter what you do, if there is one message, then avoid any sort of varus and any sort of flexion when you have a fixation of intertroch fracture. Thank you.
Thank you, Dr. Samarth. Very nice talk. And like to just thank you that the tricks you have been really giving us. Many surgeons, they learn this after making multiple mistakes. So today you have given the tricks in a handy way. So the surgeons or the residents who can adopt this immediately. Even I learned this technique maybe after doing 50 or 60 cases of trochanter fracture. Then I realized that I need to put some spikes or something. But initially I have to struggle. I have to increase the incision, all this stuff. So thank you very much. I have one question in that. Many times the lesser trochanter is far medial. Okay, in that case, you need to bring it back, would put a spike. What is the risk of having a vascular injury there?
Sir, see, we need to look at the fracture. Thank you for that question. I think that is a brilliant question. The problem is most of the time when the LT is fractured, it has the iliopsoas on top of it. So it goes in flexion and it goes slightly more medial.
Yeah.
So either you do a open reduction, or most of the time, if you have an intact lateral wall and the soft tissues on the medial side are intact and you're using a stable construct like a nail, which is more biomechanically stable, then only a small LT fragment or even a slightly large LT fragment need not be fixed. But yes, there are a lot of techniques to fix it. If you are doing an open reduction, you have to be careful of the neurovascular bundle. And there is a candy technique or a double candy technique where like you pack a candy, a toffee, and wrap it around it. So you take cerclage wire and put a candy and cerclage both on the medial and the lateral side, and you can reduce it and fix it. Yes, people do tend to use nail and plate these days to hold on to that fragment. But in my view, if you get the length, rotation, and the alignment right, fixing a small LT fragment does not matter in my view.
Okay, thank you. Any faculties, any inputs from any other faculties or any other question?
I want to ask a question.
Yeah, please.
Sir, do you use a long PFN in every case or you use a short PFN also?
So thank you, Dr. Gunjar, for asking me that. I think I have had the privilege of working with you and you have worked with me, so both of us know. But I think for the sake of audience, so I know this is a very controversial picture. Any fracture which has a subtroch extension, I think it needs a long nail. There is no doubt about it. The moment you have an intertroch fracture, which is very, very unstable, and you think there is going to be a windshield wiper effect with a very wide proximal part, I think again you need a long nail, or you need something more at the top to stop it. The moment you have a stable intertroch fracture, I think it does not matter whether you use a long nail or a short nail. For me, for my older patients to cut out on the operating time, I might need a short nail. And in my young patients, I might need a long nail. Or in my very old patients, I will use a long nail without any distal locking probably, because I want to span the entire bone. But mostly stable fractures, intertroch, small or long, does not matter. Anything with a subtroch extension for beginners, I think, needs a long nail. And anything unstable but fixed with a nail, which is not going below the subtroch level, usually is good enough with a short nail. But if the proximal canal is very, very wide and you think there is a chance of a windshield wiper effect, then it is better to use a long nail. So whenever in doubt, try to use a longer nail. And if you understand the fracture is stable, it will stay stable and it is not going below the subtroch line, I think that time you can use a short nail, especially in patients with a very high risk of fat embolism, very high risk of reaming, very high risk of cardiac risks. There you tend to use a shorter nail because you don't want to increase the pressure in the medullary canal by reaming.
So one more question. What is your weight bearing protocol after the surgery?
So I think the weight bearing protocol is same for all my patients. Every patient has to do full weight bearing only. The only option is full weight bearing, especially in the elderly patient. Anyone above 60 years of age, no matter what kind of proximal femur fracture you have fixed, unless the patient is full weight bearing, there is no other form of weight bearing. If we as surgeons think that partial weight bearing, toe touch weight bearing, or any other weight bearing is or otherwise going to work, these patients can't tolerate the amount of forces that are required for that, and more often than not all these patients will be full weight bearing. So I think we need to secure our fixations in a manner that we should allow the patients full weight bearing, because if the fixation is not stable enough, the patient is anyways going to put full weight. Yes, very young patients, probably there is possibility of doing less than full weight bearing, but there the bone quality is anyways so strong that you can allow them weight bearing. So for me, the only protocol that I follow is full weight bearing in all intertroch fractures for all my patients.
Immediately.
Immediately. So if I operate in the morning, by evening, they should be walking. If I operate them in the evening, by next morning, they should be walking. There is no doubt about it.
There is one more question from Dr. Vaibhav Mishra. His question is there any preference between 180 and 240 nails in short nails?
So, thank you, sir. That is again a very good question. So, evidence, from evidence, any nail which is less than 200 millimeters long or 200 millimeters long is called a short nail. Nail between 200 to 240, like 235, 230, 220, and 240 nails, which are common, they are actually called intermediate nails. They are not called short nails. And nails more than 320 millimeters are called long nails. So, most of the controversy whenever we talk about is between short nail and a long nail. The reason why many of the intermediate nails like a 235 or a 240 or a 220 nails stopped, or we stopped talking about them, is because they were not side specific. They were straight nails. They were left and right same. And we know there is a curve to the femur. The moment you put a 240 nail, it impinges on the anterior cortex. So sometimes intra-op you have a fracture, or post-op these patients may tend to have a lot of mid-thigh pain. So that is why a lot of us have stopped using these nails unless we are using special kind of nail which are now there in the market, which are side specific. So whenever you feel the fracture is just going up to the subtroch region, not crossing the subtroch region, and you don't want to put in a long nail, these are the conditions where you use a intermediate nail like 235 or 240 nail. And these are nails that one should use are the ones which are curved. So left and right side should be more specific than the ones which are same for both the sides. If you're using the same nail that is for both the sides, you have to be really careful, because you can have a blowout on the anterior cortex and you can fracture the anterior cortex. They are straight.
And post-op thigh pain.
And most post-op thigh pain.
Dr. Samath, there are a couple of more questions. Let me take at least one or two of them.
Vishnu, can I ask one thing?
Sir, namaste, sir, and welcome to this panel. And I just tried to introduce Dr. Vishnu Sahu. He's the superintendent of Capital Hospital and the six-time year secretary of the Association of Odisha, and is a very well teacher of most of our orthopedicians of the state. Vishnu sir, I welcome you to this webinar, and I'm very privileged
thank you. Hi, Samarth. Hi, Dr. Rastogi.
Hello, sir.
Hello, sir.
Samarth, always we try for positive reduction. Sir. Even sometimes we see when after putting the nail and everything, we have reduced it well, but after putting nail, sometimes you see that you are not able to achieve positive reduction. Yes, sometimes it goes to some sort of negative reduction. So at that time, what you do exactly? So how to achieve that?
Thank you, sir. Thank you. Lovely question. So in my talk, I said we try to reduce the fracture before. Yes, even if we do that, sometimes it tends to go in negative reduction when we get the compression.
Yes.
So at that point, what I do is, if I've not put the screw or the blade in, I've shown in two of my slides, I've used a ball spike pusher and I've used a nail jig tightener on the proximal fragment from the nail entry site, and I try to push that to get slightly more valgus. The moment I get slightly more valgus, it gets into a positive reduction, sir.
Okay. Thank you.
There is another technique, sir.
Yes.
You can put an antero-posterior Steinman pin at the fracture site.
Yes, I think that, yes, sir. Somewhere I have read that is a technique.
Yeah, and lever the proximal fragment slightly medially. So that way, and then reduce your traction a bit. That way you get a positive reduction. In fact, you get more than a positive reduction. You get an extra positive reduction, but I don't think that's a bad thing in my thing. So if you can get that, that's fine.
But extra positive reductions are maybe...
that means you get a more valgus reduction than what was the native.
you get more valgus reduction. Yeah.
So everyone, please, we have more questions, but we'll take one more question, but other question will take between other talks. Otherwise, we'll stop at the discussion only. So one question we'll take is how to manage a GT fracture after fixation of the PFN. Samath sir, would you like to answer this question?
Yeah, Dr. Vishnu, I'll be happy to answer that. I think that is a very, very good question to ask. See, most of the times, especially in the elderly patients. So let's divide this question into elderly and young. In elderly patients, these are low velocity fractures most of the times. And you see, even if the GT is greatly displaced, the moment you take them on a fracture table, they become reduced. If they don't become reduced, they are usually fallen back slightly. So what you do is when you try to make the entry point, you start off the entry with the GT, the wire in the proximal part of the GT, and then you pull the wire up towards the ceiling. So you reduce the GT with the entry wire onto the shaft.
Okay,
So
nice.
that your nail entry will start from the GT and then go on to the shaft. And the nail, when it goes in, because of the large amount of muscle attachment onto that large GT fragment, the nail will start going through the bone and through that large abductor fragment. And the moment the nail goes in, it will keep it there. You will not.
Many times it blows out. That's the problem.
So, but in elderly patients, even with the bony blowout, the muscle blowout is not there. That is what I'm trying to say. You try to reduce it with the entry point of the wire. And in the young patients with a very high velocity fracture, all you have to do is to do open reduction. With there, you have to do open reduction. You can use a small hook plate. You can use a tension band wire or something to reduce it. Young patients will be a different category. But in most old patients, you don't need to do anything more than just put a nail through that fracture fragment.
So with that, we'll go for the next presentation. I invite Dr. Kapil Pawar sir to share his screen, and he will talk on tips and tricks for management of reverse oblique fracture. Dr. Mittal, thank you very much, and I wish you will take active participation. Your inputs will be very helpful for this whole part of the discussion. We have more questions in the panel, but we'll take questions in between the talks. Otherwise, we'll stop at the discussions only. Thank you very much.
So I would request Samarth sir to kindly reply at the chat. There are some interesting questions there.
Yeah, in the meantime, you can reply, sir. That will help others. Yeah. Pawar sir, please start.